Muscles of auricle. There are three extrinsic auricular muscles such as posterior auricular muscle, PAM, superior auricular muscle, SAM, and anterior auricular muscle, AAM. There are six intrinsic muscles such as helicis major, HMJM, and minor, HMNM, tragicus, TR, antitragicus, ATR, transverse auricular muscle, TAM, and oblique, OAM, muscles. Anatomy of the human ear. The incus or anvil is a bone in the middle ear. Stapes is a small stirrup-shaped bone in the middle ear. Decompression facial nerve, INTRA temporal, lateral to geniculate ganglion. Through a postauricular incision, the physician drills out the mastoid cavity. The sigmoid sinus is exposed posteriorly. The posterior ear canal wall remains intact. The horizontal semicircular canal and part of the incus are visualized. The vertical portion of the facial nerve is exposed. The facial recess is opened and the bone over the horizontal portion, middle ear, of the facial nerve is removed. The incus may be separated from the stapes. The incus and part of the malleus may be removed. The facial nerve sheath is incised from the stylomastoid foramen to the geniculate ganglion. The postauricular wound is sutured and a dressing is applied.
Decompression facial nerve, intratemporal, including medial to geniculate ganglion. Decompression continues medial to the geniculate ganglion. The incus and part of the malleus are usually removed.
Total facial nerve decompression and/or repair may include graft. A vertical incision is made just anterior to the auricle and is extended superiorly to expose the temporalis muscle. The muscle is divided. A section of the skull, craniotomy, is removed to expose the dura over the temporal lobe of the brain. The dura is elevated off the floor of the middle fossa. The bone over the facial nerve is removed with the drill. If there is a tumor of the facial nerve, it is resected. If the nerve has been transected because of trauma, it is repaired with sutures. A nerve graft may be needed. A transmastoid approach may also be needed if extensive decompression is required. A muscle graft is placed over the floor of the middle cranial fossa. The bone plug is replaced in the skull defect. The incision is sutured and a dressing is applied. Optic nerve decompression, e.g., incision or fenestration of optic nerve sheath. The physician makes an incision in the lateral or medial aspect of the fornix. In a lateral approach, a C-shaped incision is made down to the periosteum overlying the lateral orbital rim. The periosteum is incised posterior to the rim itself. The temporalis muscle is moved aside and the globe is protected with pliable retractors. The bone is removed to access the optic nerve. In a medial approach, the conjunctiva is incised and the medial rectus muscle is temporarily disinserted. Sutures are passed through the terminal portion of the medial rectus muscle and its insertion into the globe is noted. The eye is rotated laterally to gain access to the optic nerve medially. In either case, once the nerve has been identified, several small fenestrations are made. A dissection is carried down through the outer meningeal layer covering the optic nerve until the subarachnoid space is reached. An egress of cerebral spinal fluid indicates decompression of the nerve sheath. The operative wound is closed in layers. Decompression internal auditory canal. A vertical incision is made just anterior to the auricle and is extended superiorly to expose the temporalis muscle. The muscle is divided. A section of the skull is removed to expose the dura over the temporal lobe of the brain. The dura is elevated off the floor of the middle fossa. The physician identifies the internal auditory canal. A drill is used to remove bone to open the canal. A muscle graft is placed over the internal auditory canal and the bone is replaced in the skull defect. The incision is sutured and a dressing is applied. Decompression procedure, percutaneous, of nucleus pulposus of intervertebral disc, any method utilizing needle-based technique to remove disc material under fluoroscopic imaging or other form of indirect visualization, with the use of an endoscope with discography and/or epidural injection, S, at the treated level, S, when performed, single or multiple levels, lumbar. This procedure corrects a bulge in an intervertebral disc. It is commonly referred to as percutaneous discectomy and may be accomplished by several techniques including non-automated, automated, or laser. For all techniques, the patient is placed in a spinal tap position on the left side. In a separately reportable procedure, a C-arm X-ray verifies placement of the needle in the disc. Once the disc is located, local anesthesia is injected and a small stab wound is made. A spinal needle is inserted with additional monitoring of placement and injection of anesthesia. Using a manual technique, the physician inserts 1 or 2 needles into the disc without puncturing the dura. The patient is placed on pure oxygen and the nucleus pulposus is suctioned out until the desired decompression is accomplished. The needle, S, are removed and the wound is dressed. The automated technique makes use of a probe that can simultaneously dissect the disc and suck it into the probe. Laser discectomy accomplishes the decompression by vaporizing the protruding disc. Transpendicular Approach. A technique that allows surgeons to safely access the intervertebral disc and lesions in the pedicle and vertebral body, and to decompress the neural elements through a posterior approach. Transpendicular approach with decompression of spinal cord, equina, and/or nerve root, S, e.g., herniated intervertebral disc, single segment, thoracic. Lumbar, including transfacet, or lateral extraforaminal approach, e.g., far lateral herniated intervertebral disc. Each additional segment, thoracic or lumbar. This procedure is performed to relieve pressure on the spinal cord, equina, and nerve roots caused by a herniated disc. The physician approaches the herniated disc through the pedicle on the side of the disc's bulge. Additional exposure is made by removing the lamina and facet joint. The physician removes the disc fragments and closes the wound in layers. A far lateral herniated lumbar intervertebral disc may require an alternative approach through the facet joint, transfacet, or foramina, transforaminal. Costovertebral approach with decompression of spinal cord or nerve root, S, e.g., herniated intervertebral disc, thoracic, single segment. Each additional segment. The physician makes an incision 2 inches to 3 inches lateral to the spine through fascia, muscles, and a section of a rib. The physician enters anterior to the transverse process and the pedicle using a Carrington rongeur or burr. Exposure may be increased by removal of the transverse process. The spinal cord or nerve root is decompressed by removing the herniated disc. The wound is filled with saline and radiographs are made to assure no air is leading into the lungs. The muscles fall over a drain and the tissue is closed with layered sutures. Discectomy, anterior, with decompression of spinal cord and/or nerve root, S, including osteophytectomy, cervical, single interspace. Cervical, each additional interspace. The physician performs a cervical discectomy to remove all or part of a herniated intervertebral disc. The patient is placed supine with a head halter on the jawbone, mandible. The physician makes a transverse incision overlying the intervertebral disc. The sternocleidomastoid muscle and the carotid artery are retracted. The physician excises the anterior annulus of the disc and uses pituitary forceps to remove as much disc material as possible. A spreader and microscope are used to enhance the evacuation. A drill is used to remove the transverse bar above and below. Graft material is obtained from the ilium and fashioned into a T-shape. The graft is placed into the disc space and traction is released. The muscles fall back into place and the incision is closed with layered sutures. Discectomy, anterior, with decompression of spinal cord and/or nerve root, S, including osteophytectomy, thoracic, single interspace. Thoracic, each additional interspace. The physician makes an incision along the rib corresponding to the second thoracic vertebra above the involved intervertebral disc, except in cases involving the top 5 discs. The rib is removed for access and eventually used in the graft, which is obtained through an extrapleural or transpleural approach. Vessels are tied away from the spine. The disc is removed to the posterior ligament using a microscope and nibbling instruments. The end plates are stripped of their cartilage. The physician makes a slot in one vertebral body and a hole in the other to accept the graft, which is made of several sections of rib. The physician ties the grafts together with heavy suture material and closes the tissue with layered sutures. Vertebral corpectomy, vertebral body resection, partial or complete, anterior approach with decompression of spinal cord and/or nerve root, S, cervical, single segment. Cervical, each additional segment. The patient is placed supine with traction-producing tongs. The physician makes a right transverse incision at mid-position of the planned surgical procedure, and longitudinally between the thyroid gland and the carotid sheath. The discs above and below the vertebrae are excised using a curette. Cartilaginous end plates are removed using a high-speed burr. The crushed part of the vertebral body is partially or completely removed, and the section is prepared for the graft. The anterior surfaces of the vertebrae above and below the fusion are debrided. The physician prepares a separately reportable, tricortical iliac graft and inserts it into the site, tapping it into place with a Mo impactor. Traction is released. Bone chips are packed in and, if needed, a metal plate is screwed to the spine over the graft. The muscles fall back into place and the wound is closed with layered sutures. Vertebral corpectomy, vertebral body resection, partial or complete, transthoracic approach with decompression of spinal cord and/or nerve root, thoracic, single segment. Thoracic, each additional segment. This procedure corrects compression on the spinal cord resulting from an anterior fracture of the vertebra. The patient is placed in a swimmer's position. The physician makes an incision through the fascia, muscles, and moves aside any organs. The discs above and below the vertebrae are excised using a curette. Cartilaginous end plates are removed using a high-speed burr. The crushed part of the vertebral body is partially or completely removed, and the section is prepared for the graft. The anterior surfaces of adjacent vertebrae are debrided. The physician prepares a tricortical iliac graft and inserts it into the site, tapping it into place with a Mo impactor. Traction is released. Bone chips are packed in and, if needed, a metal plate is screwed to the spine over the graft. The muscles fall back into place and the wound is closed with layered sutures. Vertebral corpectomy, vertebral body resection, partial or complete, combined thoracolumbar approach with decompression of spinal cord, cauda equina or nerve root, lower thoracic or lumbar, single segment. Each additional segment. Report if caudal equina, lower thoracic, or lumbar, single segment is involved. Vertebral corpectomy, vertebral body resection, partial or complete, transperitoneal or retroperitoneal approach with decompression of spinal cord, cauda equina or nerve root, lower thoracic, lumbar, or sacral, single segment. Each additional segment. The physician makes a transperitoneal or retroperitoneal approach through skin, fascia, muscles, and ligaments. The physician incises the anterior longitudinal ligament above and below the vertebral body. Using magnification, the physician removes the disc to the posterior longitudinal ligament using nipper instruments. The physician may use dowel or tricortical iliac grafts and prepares the site as appropriate using an osteotome. Usually 3 grafts can be inserted. They are tapped into place and surrounded with bone chips. The physician sutures the anterior longitudinal ligament. The peritoneum and abdomen are closed in the usual manner. Lateral extracovitary approach. The lateral extracovitary approach is done with a midline incision made in the area of the fractured segment and inferiorly curved out to the lateral plane. The paraspinous muscles are exposed, lifted off the spinous processes, and divided and lifted off the ribs. The targeted vertebral body is identified. The corresponding ribs are dissected from the intercostal muscles and the pleura and resected in one piece from the posterior curve to the costovertebral connection. The appropriate transverse process and part of the facet and pedicle are removed with a drill from the lateral aspect. The dura and the vertebral body are now exposed from the dorsolateral view. Vertebral corpectomy, vertebral body resection, partial or complete, lateral extracovitary approach with decompression of spinal cord and/or nerve root, e.g., for tumor or retropulsed bone fragments, thoracic, single segment. Lumbar, single segment. Thoracic or lumbar, each additional segment. A vertebral corpectomy with correction of spinal cord or nerve root compression is done for fractures or tumors of the vertebrae. The body of the vertebra may be partially or completely resected. The lateral extracovitary approach is done with a midline incision made in the area of the fractured segment and inferiorly curved out to the lateral plane. The paraspinous muscles are exposed, lifted off the spinous processes, and divided and lifted off the ribs. The targeted vertebral body is identified. The corresponding ribs are dissected from the intercostal muscles and the pleura and resected in one piece from the posterior curve to the costovertebral connection. The appropriate transverse process and part of the facet and pedicle are removed with a drill from the lateral aspect. The dura and the vertebral body are now exposed from the dorsolateral view. Further posterior and lateral access to the vertebral body is gained by gently retracting the nerve root and surrounding structures. The central portion of the vertebral body is removed with a drill, exposing more area, and any bone fragments or tumor masses are removed away from the spinal cord or nerve roots. Curettes and rongers are used to remove disc material. At this point, any necessary fusion, intervertebral reconstruction, or grafting is undertaken and reported separately. Cartilage is scraped, bone is decorticated, and an arthrodesis or reconstruction is accomplished by tapping bone graft material into the vertebral end plates. A drain is placed and closure is done in layers.